History of calcium channel blockers. In the year 980 to 1037, Avicenna, also known as Ibn Sina, had used a herbal drug known as Taxus baccata as a cardiac remedy. The leaves of the Taxus baccata contain an alkaloid mixture. Later, the drug was studied, and actually it possessed calcium channel blocking activity. Therefore, from the facts stated, it shows that this type of drug had existed long time ago, and it was found by an Islamic scholar. Then, in the year 1960s, the calcium channel blockers was discovered from pharmacological study of screen coronary dilators. This project was included in a program of pharmacological taxonomy which was initiated in Gottfried's laboratory in the year 1964. The aim of the project was to address qualitative and quantitative properties of drug either under screening or already distributed for medical use. The major basis of this program was the paper published by Arun Lakshana and Chal in the year 1959, which now recognized as the Chal plot. Basically, the Chal plot provided essentials of quantitative procedure which allowed the definition of action of antagonists and the estimate of their dissociation constant. Later, in the year 1967, Jagannath and Shepard had examined the action of a series of diphenylmethylpiperazines on contracted coronary arteries in a dog. As for clinical studies, lidoflazine had been selected for patients with angina pectoris. Besides that, Gottfried and other researchers studied the pharmacological action of lidoflazine on the isolated ileum of the angina peak, which was stimulated by angiotensin and other agonists. Therefore, from the studies, it shows that lidoflazine behaved as a calcium channel blockers. Later, many drugs were also discovered for its antagonist behavior on calcium channel.
CCB comprised of three chemical groups. First, verapamil is the only drug in this group. It binds to the V binding site. Second, benzodiazepine. Diltiazem binds to the D binding site in the L-type calcium ion channel. Third, the hydropyridine. The prototype agent is nifedipine, the first generation bind to the N binding site. Amlodipine is considered a third generation of the hydropyridine which bind to the L-type calcium ion channel.
Mechanism of action.
CCB block voltage-sensitive L-type calcium ion channel by binding to specific site of the alpha-1 subunit. It prevents the entry of calcium ion into the cell. No excitation and coupling reaction in the heart and vascular smooth muscle. Cause the relaxation of arterial smooth muscle and significant reduction in afterload. It causes coronary vasodilation. It may also slow the heart rate, relieve chest pressure, and control an irregular heartbeat. Tissue selectivity of calcium channel blockers. Characteristic of the drug. Electrophysiological studies of various compounds consider the drug potency on the L and T type of the calcium channel. Second, properties of tissue and characteristic of the stimuli. Focus on some characteristic of the selectivity of the CCB in the cardiovascular system. Tissue selectivity is used for an agent showing varying degree of potency between the tissues.
General idea of
CCB is the first line antihypertensive drug and the onset of antihypertensive is quick. Calcium ion channel consists of 5 subtypes which are L, N, T, P, and R. L-type calcium ion channel usually located in cardiac and smooth muscle cell.
Amlodipine drug design. Amlodipine development. Amlodipine is a member of the 1,4-dihydropyridine structure class of calcium antagonists. Amlodipine molecule synthesized with intention of producing a drug of comparable pharmacology profile to nifedipine but with improved oral bioavailability and long duration of action. Introduction of basic substituents into the dihydropyridine produced amlodipine that were potent calcium antagonists with the desired pharmacokinetic. Formulations of amlodipine. Formulations of amlodipine may contain its different salts such as bacillate, mesylate, or malate. These salts are considered interchangeably and the strength of the dosage form is determined in terms of the parent molecules, that is, amlodipine. Amlodipine bacillate is the most commonly used derivative of amlodipine, which is used for the preparation of its various dosage forms. The salts of amlodipine are known to affect the physical-chemical properties of the drug, as the bacillate salt is known to have better water solubility than the amlodipine alone. In vitro efficacy testing. Studies on both right aorta and dark coronary artery indicated that amlodipine was a competitive antagonist. Radioligand binding experiments designed to characterize the interactions of amlodipine with calcium channel binding sites in bovine brain and in cardiac membranes from dog and rat showed that amlodipine interacts competitively and at high affinity with the dihydropyridine recognition sites. Other than that, electrophysiological experiments conducted using isolated papillary muscles from guinea pig hearts confirmed that amlodipine was a highly selective calcium channel blocker. Besides, in vitro studies was performed to evaluate the ability of amlodipine and its enantiomer to release nitric oxide in isolated coronary microvessels and to regulate tissue oxygen consumption via nitric oxide release. It was found out that amlodipine and its R form release nitric oxide depending on the concentration and reduced oxygen consumption in canine cardiac tissues, while no effect was observed by the S form at any concentration.
In vivo efficacy testing. Studies found that amlodipine produced dose-related reduction in blood pressure of spontaneously hypertensive rat after oral administration. Besides that, amlodipine can maintain drug plasma level up to 72 hours without any first-pass effect when be administered using transdermal patch and become another alternative to treat hypertension. Moreover, in conspicuous renal hypertensive dog, oral administration of single dose of amlodipine produced dose-related reduction in blood pressure. The maximum effect was observed at 5 hours after dose, indicating the slow onset of amlodipine. Last but not least, regarding in vivo efficacy, there is still a research in innovation of amlodipine drug for effective treatment of various diseases. For clinical safety. For clinical data show that there are no special hazards caused by amlodipine for human in repeated dose toxicity, genotoxicity, and carcinogenic potential. Besides that, the rat and mice that be treated with amlodipine in diet for 2 years not even show any evidence of carcinogenicity. However, delayed onset of parturition and prolongation of contraction were noted on rat exposed to amlodipine. Hence, the use of amlodipine for pregnant women and during lactation should be avoided, although there are still no data that show the dangers of amlodipine during pregnancy.
The Phase 3 clinical trial for amlodipine bacillate was conducted for 8 weeks. Male and female patients aged 18 to 75 years old, having uncomplicated mild to moderate hypertension, not received any hypertensive drug in 2 weeks before the random trial, and having sitting diastolic blood pressure SIDBP equal to 90 to less than 110 mm mercury was eligible for this random clinical trial. 94 patients treated included in intent to treat, ITT analysis, and 81 out of 94 patients were included in per protocol PP analysis. The patients were given 5 mg of amlodipine bacillate every morning once a day for the first 4 weeks. If either the blood pressure was more than or equal to 140 over more than or equal to 90 mm mercury, or SIDBP not decreased by more than or equal to 10 mm mercury after the first 4 weeks, the dose was increased to 10 mg once a day. The result for the clinical trial is the mean sitting systolic blood pressure SISDP and SIDBP significantly decreased from the baseline. It decreased from 146.8 over 96.7 mm mercury to 128 over 83.8 mm mercury. The most common adverse effects were dizziness and dyspnea, and it affected only 1 out of the 94 patients.
Now we move on to drug manufacturing in large production. In all dosage form, the most preferable form is tablets, and it is commercially available in once daily doses of 5 mg and 10 mg. Here are some of the brand names in tablet form, which are Nulop and Norvasc. The manufacturer usually using direct compression method because it is simple, cheaper and faster. This method involves only two operations in sequence. The first one is powder mixing and second one is tablet manufacturing. For drug formulation, the active ingredient is amlodipine bisilate and excipients are microcrystalline cellulose as compressible agent, lactose anhydrous as filler to help increase the size of tablet, sodium starch glycolate and cross caramelose sodium act as super disintegrants, and magnesium stearate act as the lubricant which prevent ingredient sticks to manufacturing equipment during compression process to convert granule into tablets. And this is how the amlodipine bisilate tablet is produced. And then the tablets undergo QC test. Average tablet weight was determined by weighing some of the tablets individually by means of an analytical balance for weight variation test. For thickness test, some of the tablets were taken in their thickness was determined individually by means of vernier caliper. The tablet must undergo hardness test to determine the endurance of the tablets for storage, transportation and handling before usage. Friability test is important to analyze the tendency of tablets to crumble or break once compressed. And lastly, the tablet must undergo disintegration test to ensure good bioavailability by having a lesser disintegration time by controlling the pH level and temperature.
Amlodipine has several adverse effects. Adverse effects of amlodipine are divided into common adverse effect and severe adverse effect. Common adverse effect of amlodipine is swelling of leg or ankle, tremor. Tremor is an unintentional and uncontrollable rhythmic movement of one part or one limb of your body. It can occur in any part of the body and at any time. And the third one is irregular heart rate, which is known as arrhythmia. Severe adverse effect of amlodipine is severe dizziness, lightheadedness, fainting, and more chest pain or heart attack. Chest pain or heart attack is due to when you first start taking amlodipine or increase your dosage, your chest pain may get worse or you may have a heart attack. There are also allergy warning of amlodipine. It can cause a severe allergic reaction. The symptoms of allergic reaction of amlodipine are trouble breathing, swelling of throat or tongue, hive or known as urticaria. It is an itchy, raised welts that are found on the skin. They are usually red, pink or flesh colored and sometimes they sting or hurt. Calcium channel blocker therapy is usually associated with frequency of edema. Calcium channel blocker treatment is associated with peripheral edema. It is due to more potent calcium channel blocker like amlodipine will be associated with high rates of edema. The factors of edema that caused by calcium channel blocker like amlodipine is occur when the amlodipine is reducing the arteriolar resistance that goes unmatched in the venous circulation. This disproportionate change in resistance will increase the hydrostatic pressures in the precapillary circulation and permits fluid shifts into the interstitial compartment. This calcium channel blocker related edema usually occur in women.
There are numbers of strategies exist to treat calcium channel blocker related edema. The first one is conversion from a dihydropyridine calcium channel blocker to a non-dihydropyridine calcium channel blocker. Non-dihydropyridine calcium channel blocker tend to be less potent vasodilators than dihydropyridine calcium channel blocker. Thus, non-dihydropyridine calcium channel blocker such as verapamil and diltiazem are less likely associated with peripheral edema. The second one is use a venodilator drug such as angiotensin converting enzyme inhibitors, angiotensin receptor blocker, and or nitrate as a means to reduce the venous hypertension. Addition of an ACE inhibitors or an ARB to a regimen of calcium channel blockers monotherapy reduce the pressure within the capillary bed, thereby reduce the formation of edema. The next strategy to treat the calcium channel blocker related edema is by reduction dose of calcium channel blocker itself. Lastly, the calcium channel blocker may need to be stopped if the management strategy outlined before fail.
Issues on calcium channel blocker. Their suitability as the first-line drugs in mild hypertension and appropriateness in certain patients are the problems. The questions relate mainly to the dihydropyridine subgroup, which includes short-acting and long-acting nifedipine. The short-acting nifedipine preparations were the first to achieve clinical popularity. After short-acting nifedipine was released, it was found to provoke angina and myocardial infarction. However, series of studies revealed that patients who take calcium channel blocker had higher risk of myocardial infarction. In a meta-analysis of randomized trials showed that patients who had been treated with nifedipine and having acute myocardial infarction or unstable angina were at a higher risk of death. Meanwhile, subgroup analysis showed that the risk of adverse effect confined to patients who received doses of more than 60 mg per day. Other studies described the higher risk of cancer, suicide, and gastrointestinal hemorrhage among the users of calcium channel blocker. However, the association related so far is relatively weak and inconsistent. In the large randomized trials of newer calcium channel blocker, the long-acting drug nitrandipine reduced the incidence of stroke. Meanwhile, appropriate blood pressure control in diabetes or ABCD trials that compared nisoldipine and enalapril was stopped because of excess of myocardial infarction among the patients. However, it was unclear whether if that was an adverse effect of calcium channel blocker or the beneficial effect of enalapril. In short, the data provide evidence that harmful results may available if used short-acting nifedipine in higher dose. So for the initial management of hypertension of patients with diabetes, ACE inhibitors is preferable to dihydropyridine.